Bonjour Anaïs, est-ce que tu nous entends? Est-ce que tu peux allumer ton caméra si possible? Et on fait un petit test.
Salut. Salut.
Merci beaucoup.
C'est bon?
C'est très bon. Tout petit peu plus. Headroom, juste un peu. Ouais, ça c'est trop. Entre les deux. Ouais, parfait. Merci beaucoup. Et si tu peux laisser ton caméra allumée, s'il vous plaît?
Allumé, ok.
Oui. Tu peux muter comme tu veux.
Chris? Hi, Chris. I'm not hearing yet. Is that normal? Oui, ça va commencer, je crois. C'est vide, hein, là. Attends. Oui, ça va commencer. Ah.
Salut Anne. Je sais pas si tu me vois.
Oui, non, je te vois pas, mais je t'entends. Ok, super.
Oui, ça n'a pas commencé encore. Je pense qu'ils sont en train de set up. Il y a des gens qui sont en train d'avancer. Comment tu vas?
Écoute, ça va. Là, je viens de sortir en fin de Bounia. Je viens juste d'atterrir à NTB. Là, je suis dans la voiture. J'ai juste. Anaïs?
Oui, je pense que Chris nous avait muté.
Ok, d'accord. Ok, salut Chris. Allez, je ferme.
Recording in progress.
Hello and welcome to WHO. It's Friday, 22nd May, and welcome to our hybrid press conference on Ebola, the ongoing World Health Assembly and other global health issues. My name is Christian Lindmeier, and we'll be together for the next 45 minutes or so. Let me introduce the panel first, before we go into introductory remarks. Of course, first and foremost, Dr. Tedros Adhanom Ghebreyesus, Director General. Next to him is Dr. Mohamed Yaqub Janabi, WHO Regional Director for Africa. Very happy to have him here. Then we have Dr. Ghebreyesus. He's the Executive Director for WHO's Health Emergencies Program. Next to him is Dr. Abdi Mahmoud, Director of Health Emergency Alert and Response Operations. On the other side, we have Dr. Sylvie Briand, WHO Chief Scientist, and next to her is Dr. Maria van Kerkhove, Interim Director of WHO's Department of Pandemic Management. We have a couple of other colleagues online. One to mention is we have Dr. Ann Ansia available. She's the WHO representative to the Democratic Republic of the Congo. She's currently in the field, so we hope we could get her connected in case, but we'll see other colleagues in case we get to them. With this, enough of me, and over to Dr. Tedros.
Thank you, Christian. Good afternoon to everyone in the room, and good morning, good afternoon, and good evening to those joining us online. The Ebola outbreak in the Democratic Republic of the Congo is spreading rapidly. Previously, WHO assessed the risk as high at the national and regional levels and low at global levels. We're now revising our risk assessment to very high at the national level, high at the regional level, and low at global level. So far, 82 cases have been confirmed in DRC, with 7 confirmed deaths. But we know the epidemic in DRC is much larger. There are now almost 750 suspected cases and 177 suspected deaths. The situation in Uganda is stable, with 2 cases confirmed in people who traveled from DRC, with 1 death. The measures taken in Uganda, including intense contact tracing and cancelling the Martyrs' Day commemoration, appear to have been effective in preventing the further spread of the virus. An American national who was working in DRC has also been confirmed positive and transferred to Germany for care. We're also aware of reports today about another American national who is the high-risk contact, who has been transferred to the Czech Republic. The governments of DRC and Uganda are leading the response with support from WHO and partners. In addition to our national staff in DRC, so far we have deployed 22 international staff to the field, including some of our most experienced people. And we have released $3.9 million from the Contingency Fund for Emergencies. We're also in touch with UN Humanitarian Chief Tom Fletcher, and I thank him for allocating $60 million to the response. On the ground, we're supporting national authorities with every pillar of the response, including contact tracing, establishing treatment centers, risk communication, and community engagement, and more. Together with the Africa CDC, WHO is also establishing a continental incident management support team. In the coming days, we will publish a multi-agency strategic preparedness and response plan, SPRP, aligned with the national plans of both DRC and Uganda and with our partners. As you know, unlike many previous Ebola outbreaks, which were caused by Zaire virus, this outbreak is caused by the Bundibugyo virus, for which there are no approved vaccines or therapeutics. There have only been 2 previous outbreaks of Bundibugyo in Uganda and 2000 and in DRC in 2012. Yesterday, WHO convened the leaders of several partner organizations under the Interim Medical Countermeasures Network to review the pipeline of vaccines, therapeutics, and diagnostics. The WHO R&D blueprint has also convened its technical advisory group on therapeutics and recommended to prioritize 2 monoclonal antibodies to advance in clinical trials. In addition, the advisory group recommended the evaluation of antiviral obeldesivir in a clinical trial as post-exposure prophylaxis for people who are high-risk contacts. This clinical trial is now being developed jointly with Africa CDC and the Collaborative Open Research Consortium on filoviruses. We're also discussing with partners candidate vaccines in the development and manufacturing pipeline. As you know, the provinces of Ituri and North Kivu, in which the outbreak is occurring, are highly insecure, with intensified fighting in recent months, causing more than 100,000 people to be newly displaced. Across both provinces, around 4 million people need urgent humanitarian assistance, 2 million are displaced, and 10 million face acute hunger. There is also significant distrust of outside authorities among the local population. Just yesterday, there was a security incident at a hospital in Ituri where tents and medical supplies were set on fire. Building trust in the affected communities is critical to a successful response and is one of our highest priorities. We're also committed to ensuring that essential health services for the affected communities are maintained and strengthened based on their needs. Now, a brief update on the hantavirus outbreak among passengers and crew on board the cruise ship MV Hondius. Today, the Netherlands confirmed an additional case among a crew member who disembarked in Tenerife, who was repatriated to the Netherlands and has been isolating since then. There are now 12 reported cases and 3 reported deaths. No deaths have been reported since the 2nd of May, when the outbreak was first reported to WHO. We continue to urge affected countries to monitor all passengers and crew carefully for the remainder of the quarantine period. More than 600 contacts continue to be followed in 30 countries, and a small number of high-risk contacts are still being located. Once again, I thank the many countries that have cooperated in the response and the epidemiological investigation. Argentina, Cabo Verde, Chile, Netherlands, South Africa, Spain, the United Kingdom, and the European Union. Christian, back to you.
Thank you very much, Dr. Tedros. We're now ready for your questions. As usual, please raise your hand, either here in the room or with the raise your hand icon. We'll take first question from the room and then go to the online platform. And please, again, introduce yourself, because not everybody here is familiar with you. Laurent, let's start with you.
Yeah, Laurent Siro, Swiss News Agency. Thanks for the briefing. So you mentioned the efficiency of contact tracing in Uganda. What about the impact of this security overall situation and incidents on the contact tracing in Turi? And also, maybe, are you concerned with the spreading now also in South Kivu? There seems to be a few cases there. How do you see the situation there? Thank you.
Dr. Mahmoud, please. Ano? Oh, yeah, that's true. We can see if Dr. Anansia is available. Dr. Ansia, are you connected and available? We have her. Let's see if we can get on.
Yes, I am will hold. Yes. So, yes. What we know, I'm going to start by South and North Kivu, where we know that contact tracing has been sufficiently effective for the time being. The new case that was confirmed in Ruiro in South Kivu yesterday morning, there is 89 contacts that are already being traced there. In North Kivu, where we've got one case in Goma, the situation is similar. We've got around 80% of contact tracing going on for the time being. However, this is unfortunately not the situation that we are facing in Bunia as we talk. Yesterday evening, by the end of the day, we knew that we had 11% of contact tracing. So we still very low. And as you mentioned very well, the problem that we faced, the security problem that we faced yesterday in Rwampara will significantly jeopardize the very strong operation and rapid operation that we were initiating in Rwampara, which is one of the 3 hottest spots of the outbreak response for the time being. This morning, we had our security team in Rwampara with the governor and the provincial health authorities, talking to the population, discussing calming messages, risk protection, able to start again tomorrow.
Thank you very much, Dr. Ansia. We can move to the next question, please.
Operation will be able to start again tomorrow.
Thank you very much, Dr. Ansia. We can move to the next question, please.
Good afternoon. This is Preeti Patnaik from Geneva Health Files. I had 2 quick questions. One on whether the WHO is already suggesting any kind of existing drugs that can be repurposed, existing therapeutics. And second, can you explain to us how the interim medical countermeasures platform is working right now during Ebola? Is it underfunded, or what are the challenges?
Dr. Vrion.
Yeah. So thank you very much for the question. And as Dr. Tedros said, there is already some drugs that have been identified for the treatment of patients. These drugs were repurposed because they were used before for other strain of Ebola viruses, but it happens that in the test that they have some efficacy on also this strain of Bundibugyo strain. So we have as a therapeutic, so 2 monoclonal antibodies could be used, and 1 antiviral also can be used for treatment. And so these has been defined by a technical advisory group that met earlier this week. And so what we do is we make an inventory of all the things that are potentially useful or in the pipeline. And then the committee look at prioritize them using a number of criteria. So, of course, the main criteria are their safety and efficacy on this current strain. But then also we look at criteria for implementation. So we are not yet at this phase of criteria for implementation because the committee looked only at the drugs that are available. And now we will discuss with other partners and health authorities to see how we can implement them. So one very important step before implementation is really the development of a protocol to be adopted by all the partners and of course the country, and making sure that the protocol makes sense in this particular context, and also that this protocol is strict so that it protects the patient, but also allows us to gather meaningful data that can be then used also to adjust the implementation as we go. I think for in addition for the antiviral, one antiviral called Obeldesivir, we think that it could be used also for post-exposure prophylaxis, meaning given to contacts. And then this would prevent those contacts, should have they been infected by the virus, to develop the disease. And so this is a promising treatment, drug, but it has still to be implemented under a very, very strict protocol. So regarding your second question about this network for medical countermeasures, so why it is important to have those platforms? It's first because this platform is not only activated for a crisis. It works throughout the year between epidemics and brings together all the partners that have some stake into supporting the research, but also the development and the implementation of medical countermeasures. So, and it's very important that those partnerships are not built just for crisis. They are built for all the time. But when we have a specific crisis, we activate specific groups or subgroups of this platform. And so, for instance, in the research and development, we have what we call CORCs, that are collaborative open research consortium. And we have 12 CORCs currently. And those CORCs are groups of researchers and scientists all over the world that are interested in a specific family of viruses. And so the CORC on filovirus is currently meeting as I speak. They started their meeting today at 1 and they will finish at 4. And they are discussing all the possible gaps in research that we need to fill urgently, but also looking at clinical history and evolution of the virus. They are also looking at the countermeasure that could be available and what are the criteria for prioritizing them. So the CORCs are really an essential component of this global research ecosystem for emerging pathogens. And so on vaccine, I don't know, maybe I can give the floor to Vazi if you want to talk a bit more about what has happened in the tag for vaccine.
Yeah, we also have in the room Dr. Vazi Moti. He's the acting lead for the R&D blueprint. Please, over to you.
Thank you. So on the vaccines R&D tag, they met earlier this week. They are continuing their deliberations and they will be meeting again on Monday. But I think the important point to stress is that we already have, I think we need to present this and communicate this as treatment of cases and prevention of cases. So we already have something prioritized under a strict protocol for prevention of cases, and that's the oral Obeldesivir that has already been mentioned. But we're still under the deliberations for the vaccines R&D tag. If there are specific questions on candidate pipeline vaccines, I can take them.
Thank you very much.
Sorry, Christian, may I please come in on the ICM? So just specifically on the IMCM net that you asked about. So in addition to what Sylvia said, indeed, this interim medical countermeasures network has been established over the last several years, and it is activated all the time. It is working all of the time, and when we do have outbreaks like this, there's much more activity. So the IMCM net covers diagnostics, therapeutics, vaccines, other health products as well. I know there's a lot of discussion around vaccines, but also want to say that there's as much emphasis on diagnostics and also on treatments as well, as you've heard. The IMCM net is fully activated on a technical level. We have different working groups. There's a meeting today for the diagnostics team, specifically to look at bringing in global, regional partners from DRC on the call to coordinate how these diagnostics can be used and what can be used. We know the gene expert isn't good for Bunin-Bujo virus, but there are other diagnostics that do work. And so we're wanting to make sure that those are the ones that are in the field and those can be procured, and working with our OSL partners within this as well. Yesterday, the DG convened the principals of the agencies leading work on medical countermeasures, whether it's CEPI or the Global Fund or Gates Foundation, or I shouldn't name some or else I won't name them all, but the principals of these agencies to ensure that we are all aligned and that we are all working together on this. I think this is really important. This is one of these situations where it's sort of an all hands on deck. And we want to make sure that everybody is coordinated in their action and working together, that we're all on the same page, we're holding each other's organizations and institutions accountable for the speciality that they actually have, and to ensure that we all have accurate information, up-to-date information, and that we're speaking the same language as we talk about the risks, we talk about the products, we talk about what needs to be done. So the DG convened that meeting yesterday. It was actually held here in person. RD was there as well, Chikwe was there as well. We hope to convene this group periodically to make sure that they are up to date, but they gave their full commitment as well. I should mention Gavi too, but they gave their full commitment in support of this outbreak with all of their institution and the knowledge that they have.
Thank you, and our regional director also wanted to add.
Yeah, thank you. We have strong tools, but not all are optimized for this strain. It has to be. So this outbreak really highlights three things: the need for broader vaccine and therapies, stronger research and development pipelines, and adequate access to medical countermeasures. So this is on top of what my colleagues have said. Thank you. Back to you.
Thank you very much. Let me flag already to everybody that we have a big number of questions online and also in the room. So we go now first for two questions online, and we'll actually start with The Guardian. Katlai, welcome back. Over to you. Please unmute.
Thank you very much for doing this. I had a question around treatment centres in the DRC. Do you have an assessment of how many are needed, and when do you expect those to be up and running? And also, can anyone speak to the situation in South Sudan and whether there's adequate surveillance, and you would expect to receive a notification of any potential cases there fairly swiftly? Thank you.
Thank you very much, Kat. For the first part, we'll try to get back to Dr. Asser in the DRC.
Yes. Yeah, once again, just to come back to the situation in Rwampara, which has been very sad, because actually what we were doing there with the NGO Alima, we were actually taking out the cases that were in the main hospital in Rwampara and trying to put them in the tent in the courtyard of the hospital to really separate them from the other cases that are in the hospital and who are receiving routine health services. In Rwampara, we have now identified as well another hospital where we were hoping actually this morning to start transferring those patients from the routine hospital to that specific hospital, which we were preparing to receive those cases since the past 2 days. So if operation can restart in Rwampara tomorrow, we will have our first hospital with the basic services, but with very strong infection prevention and control measures in place so that really we are stopping a potential dissemination of the infection within the health infrastructure. In the meantime, in Bunia, we have also the organization Samaritan Purse, who is looking at supporting the provincial hospital with setting up the case management center. In the similar wave, in the Mongwalu, you've got Doctor Without Border from Switzerland, who is also right now working hand in hand with the zonal authorities there and with the World Health Organization to build the treatment center. We will also look at the health zone that has been affected, and we will try to have, for the time being, a treatment center in each of those health zones. For example, in Bamboo, which is a health zone that is being affected since yesterday, we had already identified a potential treatment zone. Now that there are affected cases, we will start scaling up this health facility so that it can become a treatment zone. So we have decided yesterday that with the number of suspected cases that we've got for the time being, we need to have a treatment center in each health zone that is affected. This will also allow to decrease the movement of population, which we know is actually really hampering our work to be able to disrupt the transmission of the disease. Over.
Thank you very much, Dr. Ancian. We go for the South Sudan to Dr. Mahmoud.
Thanks for that question. I just wanted to tell people how the surveillance works. In the surveillance, we have what we call alerts, where the community does the first line of defense, where the community leaders start reporting unusually deaths and suspected. From there, clinical work, clinician healthcare workers go and assess that and triage. So you move from an alert to suspected, we collect samples and it becomes a confirm. We will be getting more alerts, and it's really good to have those alerts and to be investigated. We had alert from South Sudan, we have alert from Kenya, and the government of Kenya confirmed that investigation was done, was discarded. So that's a function of a well-defined system. So alerts are not bad, it needs to be investigated, and we're encouraging all the countries in the neighboring regions to strengthen their surveillance, involve the community. So we pick the initial alert and we deploy healthcare workers to investigate those alerts, and then we put them either suspected or confirmed case.
The second part on South Sudan, can we answer that?
Yes, we don't have currently, we don't have any confirmed. We have alert, which is good.
Perfect. The next question goes to AFP. Agnes, please go ahead. Agnes, do we have you? If not, then I move to DPA, Christiane Oelrich. Christiane, please go ahead. And if neither DPA nor AFP want to talk to us, who do we have?
It takes a while to get unmuted.
You're very distant.
It takes a while to get unmuted.
Here we go.
That's the problem. Here we go. Talking about the antiviral that could be given to contacts, can you give us a timeline on when that might be available? If I understood correctly, you are now setting up a clinical trial. Does a clinical trial involve giving placebo to half the people who are in the trial, and for how long is a trial going on before this could actually be available if it turns out to be efficient? A timeline, that's my question.
Very good, thank you. And we want to start with Dr. Briand, please, yes.
So first, what we do currently is we define the protocol. How the drug will be used and as you rightly said, the different arms of the clinical trial. The plan is to have a multiple arm, and I will let Vazi explain it a little bit further, but really, so the timeline depends on two things. First is the fact that we need to agree on the protocol, and the national authorities need also to agree on this protocol. The protocol is not done by somebody in Geneva in an office. It's done jointly with experts in the field and internationally. And then we need also to make sure that the monoclonal antibody and the antivirals are available in the field. So these are negotiations that will be carried out with the manufacturers or the institution who have got the monoclonal antibodies to see how fast they can deploy those products in the field. We need also in parallel to make sure that we have people in the field able also to support the local authorities to implement the protocol. So maybe Dr. Vazi, you want to give more details on the arms of the clinical protocol? Over to you.
Yes, thank you. Just to stress, I think the most important thing is as with all of our work, our role is for WHO to support the countries. So this is very much for the national authorities to decide. But we do have all of the world's leading experts meeting together, including from within the affected areas on the protocol. Just some practical issues on next steps before proceeding. Obviously, again, any clinical trial would be integrated into the response. So that's a very, very central part of it. Secondly, there will need to be export of the study drugs from where they are currently. There will need to be, so there are export permits, there will need to be import permits that are provided by the affected countries. That usually requires an approved protocol. So the protocol, once it's developed with a lot of input from many partners, and most importantly in country, will be submitted for review by ethics committee and regulatory authority in each of the affected countries. After that is approved, then usually one proceeds with the import, unless the countries decide that can be done in parallel. So those are some practical matters. In terms of how long it would run for, that all depends on exactly what one sees. There will be an independent data safety monitoring committee that would be set up, which would look independent to the trial at how the study drug appears to be working. And as soon as it is, if we get to the point where it clearly is beneficial, then the study would be stopped and we would move beyond the study phase.
Thank you very much, both. We go back to the room to see what we have here. If we have nothing in the room, that's luck for those online. We have at least got 10 more online. So then we go next to the Lancet, Paul Adeboju. Paul, please go ahead.
Thank you very much for taking my questions. So I think the Bundibugyo Ebola outbreak shows that global preparedness is still too reactive and too focused on better known pathogens. So what specific investment does WHO believe donors should protect now to ensure surveillance, diagnostics, and countermeasures are ready before the next rare outbreak begins? Then my second question is that this outbreak is the kind of threat that the pandemic treaty is supposed to prepare the world for. But the treaty still has major gaps in how the preparedness would actually be financed, operationalized, and made equitable. So how does WHO see the outbreak testing the unfinished parts of the pandemic agreement, particularly on pathogen sharing, equitable access to diagnostics, countermeasures, and sustained financing for preparedness before rare but high-risk pathogens emerge? Thank you very much.
Thank you very much. We'll start with Dr. Van Kerkhoff.
Yeah, thanks. I'm sure many might want to come in on this one because it's a great question. The point around what types of capacities do we need to, I'm going to cover the capacities part of things because what we do at the World Health Organization as the Secretariat of all member states and all of you is really to ensure and work with ministries of health across different sectors to ensure that there's a certain level of capacities are in existence. You're very well aware of the international health regulations, looking at what capacities, core capacities that are needed in every country. And what you mentioned in your question, surveillance, making sure that there's good surveillance in each country, that there's a workforce that is trained, that is protected, that we have good laboratory systems in place with the right diagnostics, the right reagents, and all the way through appropriate clinical care, looking at infection prevention and control, looking at emergency coordination in each country, making sure that there's provision for community protection. So there are all of these core capacities that we work on, and we look at the threats from many different lenses. I'm sure Sylvie will want to come in and talk about the R&D blueprint and the work that they do through that as well, looking at viral families. We need to be prepared for any type of hazard, whether it's a known biological hazard, respiratory diseases, for example. We're constantly preparing for the next flu pandemic because we know it's not a matter of if, it's a matter of when. But we're looking at respiratory diseases more as a whole instead of individual pathogens. We're looking at arboviruses and the risks to arboviruses across the globe. And with climate change, the risks are growing with 4 billion people at risk for arboviruses, and that will increase to 5 billion in the next few years because vectors are moving further north and further south. We look at bacterial threats as a whole and look at what can be done in understanding, improving water and sanitation so that we can prevent outbreaks of cholera, for example. And we also look at the high threat pathogens like we see with Bunyibugyo. We look at Mpox, we look at different Ebola viruses, hantaviruses, and just having those capacities ready. In addition to that, with the IHR, having the information sharing system, you heard the DG say in his speech here, there were hundreds of communications related to our national focal points in each country, sharing information about this hantavirus outbreak that was contained to a ship, but involved many people on the ship who left the ship, who traveled on planes, who were repatriated home, but sharing of that information through the national focal points are capacities in countries that are also really, really critical. But not only having those capacities in place, having the financing to be able to support that. And many governments are struggling at the moment with this because a lot of funding that was previously identified to be used for health is moving towards defense. There have been some mechanisms put in place like the Pandemic Fund, which is issued more than $1 billion to support surveillance, laboratory systems, workforce. I could go on, but I think your point is really pivotal, that we need countries to be ready. We need governments to be ready to scale up and to scale down for that early detection. Financing is critical on this. And those capacities in countries and supporting those capacities in countries are what will really enable that early detection and critically that early action. And maybe Nadrat wants to come in on the pandemic treaty, but this is what the member states are negotiating right now. This is what they're here doing at the World Health Assembly right now here in Switzerland. But this is something we want to ensure countries have at a consistent level, because these outbreaks, they don't care who's in power. They transcend any election cycle that we have. So these consistent capacities in countries are what's key.
Thank you very much for the question. I think there are two legally binding global international instruments which are critically important for pandemic prevention, preparedness, and response. One of them is, as Maria mentioned, the international health regulations. In addition to building the core capacities, it requests the member states to report any detection immediately. And then there is the mechanism of emergency committee and director general going towards the public health emergency of international concern declaration. This is supplemented by another, hopefully will become an international legally instrument, is the pandemic agreement. That brings, in addition to the mechanisms to build those core capacities required in the countries, it also brings a strong pathogen sharing and benefit system, which is still under negotiation by the member states. So what we see within the Ebola, there has been an immediate sharing, which is a good news, and it has been done voluntarily. That we are grateful to the countries who has been sharing those pathogens for years, that we have many examples. But at the same time, linked to that on an equal footing, the benefits which are being produced by using those pathogens, particularly the vaccines, treatments, and diagnostics, are going to be also used as a global public good in line with the needs of the countries. And actually, there has been discussions on what those benefits could be in support of response into a public health emergency of international concern. And I'm sure that's going to help us a lot in the negotiations. Thank you.
Yeah, thank you. It was a multifaceted question, so we also have a couple of colleagues coming in. Dr. Ansier from the DRC wants to add.
Yeah, just a couple of points. I wanted to say that from us, as soon as we went into the response mode for this outbreak, from the start, we decided that we would have an approach that will really strengthen the systems that are in place for the time being, as well as strengthening preparedness in the provinces that are affected, and as well this will ripple down at all level of the health system here. So we really think that as soon as you start a response, you have to look at how you can really strengthen the system. An example that I can give we are looking right now exactly at how we will support laboratories to make sure that we will be able to strengthen the laboratory network in the Democratic Republic of Congo, as we did, for example, during the Mpox response. You know, when we started the Mpox response, there was only 2 laboratory who could diagnose Mpox. And as of today, we've got more than 60 sites that can actually now diagnose Mpox. So we intend to do exactly and having exactly the same approach for the response to Ebola. I promised to the governor as I left Bunia this morning, I told him, trust us, we will make sure that when we leave, when we have finished with this response, you will have stronger system, stronger human resources who can do infection, who can do infection prevention and control, who can do investigation. You'll have laboratory that will be equipped. You will have human resources who know how to treat those things. So this is extremely important. And I can say as well that actually the preparedness that WHO and other partners has been working on in countries like DRC is also already ripening some fruit. The 40 experts that we managed to mobilize and to bring on the ground as of Sunday on day 3 of the response are people that have been trained, that are working together. They're coming from the Emergency Operations Center that has been established since 2022 in DRC, and which is already an excellent center for emergency operation in DRC and also in the sub-region. And I have observed myself the human resources that have been deployed, both from the Ministry of Health and from the World Health Organization. I have witnessed their knowledge, their expertise. The incident management system was established in no time, and the response operation were really able to be set up very quickly because those people, those human resources have benefited on support, on preparedness from years. And this is really what I want to say. If we want to have good response operation, we need to invest more and more and more into preparedness. Thank you.
Thank you very much to all speakers. Now we'll try again with Agnes Pedrero from AFP. Let's see if we can connect her. If not, I have it in writing. No, then let me read it out. My question is, what does it mean that the risk is very high at national level? So clarification on that, please. What are the implications, and is it the highest level? And on the treatments that have been submitted by WHO to study, could you give us the names, please? On Dr. Mahmoud, on the risk level.
Thanks. Bear with me, I will explain, because this is an overall risk assessment. When we do a risk assessment, we answer 3 questions. 1, the potential risk for human health. 2, risk of an event is spreading. 3rd is the capacity available. And then from there, we look what's the likelihood and the consequence. From there, we assess. Looking right now, what clearly changed from when we did the initial risk assessment is the risk of event spreading has gone from a moderate to high, and the risk has gone very high. We have seen now evidence in South Kivu, Mitumaharisa, in Goma, in all the places, in the 2 imported cases. So the potential of this virus is spreading rapidly is high, very high, and that changed the whole dynamic. Linked to that is the capacity to respond to this outbreak. Insufficient control. DG was very clear that you was in a humanitarian situation. So when you combine these two, the risk shift from high to very high in Eastern DRC. And there's the urgent need required in solidarity and in support of that rather than travel restriction and ban. We need humanitarian access. We need flight to go there. We need to stand with the local authority and all the NGOs working there. Is the time for solidarity. So the slightly change is because of what we are seeing, the epidemiology-driven data. But if we implement all the containment activity, the contact tracing, the building the trust with the community, expanding the lab, our representative already indicated what we are doing there, we will be able to this and reduce the risk from very high to high and hopefully moderate. But it requires global solidarity.
Thank you. And we have Teresa Zakaria, Unit Head for Risk Reduction and Humanitarian Operations on the humanitarian side.
Thank you very much. To build in slightly as well on the capacity to respond, indeed, the outbreak is currently spreading in area that is affected by conflict. There are over 2 million people who have been forcibly displaced in these 2 provinces alone, and close to 10 million people are desperately hungry at the moment. Last year, 1.5 million people have additionally lost access to primary health care facilities, and we know from our partners that 85% of facilities face critical drug shortages. So what all of these mean is that people, even if people are sick, they may be suspect cases, they cannot access health services, and therefore they cannot be detected, they cannot be diagnosed. And it is very important to highlight that within the outbreak response as well, we need to really make sure that essential health services for everyone in the 2 provinces are safeguarded, especially for those who have been forcibly displaced and extremely vulnerable. Thank you.
Thank you very much. I see Emma Farge out there, but wait, Emma, we have one more now online because there's many online, and then afterwards I'll come to you. Sorry for that now. So now we go to Kai Kupferschmidt from Science Magazine. Kai, please go ahead.
Thank you. I hope you can hear me. Sorry, I'm on a train, so my connection is cutting in and out. Apologies if you've already mentioned it, but I wanted to make sure, what are the 3 treatments you're talking about? It was my understanding there's the MapBio antibody, there's remdesivir, but you mentioned the second antibody. Could you just go through the actual drugs that were prioritized? Thanks.
Thank you, and we start with Dr. Briand.
So the technical advisory group has prioritized for treatment the 2 monoclonal antibodies. One is Regeneron, but it's the 3479, and the other is, as you said, MapBio, MBP 134. And for the antiviral, intravenous antiviral is remdesivir. Then for post-exposure prophylaxis, it's obeldesivir that has been prioritized.
Thank you. Thank you very much. Now we come back to the room, and Emma Farge, Reuters, please.
Yes, thank you. A question for Dr. Ansha, please, and maybe one for Dr. Van Kerkhove as well. So the first one, the numbers of cases are rising very quickly. Is that normal at this stage of an epidemic? How does it compare to other outbreaks? And was there a super spreader event that has caused the numbers to rise so quickly? And if you have the number of people being traced, I'd appreciate that as well. And then, Dr. Van Kerkhove, you mentioned the financing and the fact that money is being diverted to defense. Do you have any idea how much this outbreak will cost and if those resources are available? Thank you.
And let's see for Dr. Ansia.
Can you, I am sorry, we were in an area where I could not hear the question, I just hear the end. The number of people being traced in Ituri for the time being is more than 1,400.
Emma, could we briefly repeat the
I didn't
first
hear
part?
the first part of the question. Can you
Yes,
repeat?
thank you. I was wondering what it means, the fact that the cases are rising so quickly. Is that normal at this stage of an epidemic? Was there a super spreader event? Thank you.
No, I do think that having the number rising is probably good. It means that our surveillance is working. What we are doing right now, and what we had prioritized, is actually active search of cases. We need to have all the suspected and confirmed cases being brought to health facilities so that they can receive treatment. And we need, from all those cases, we need to have the list of their contacts so that we can find those contacts, trace them, isolate them for 21 days, because it is the only way that we will, at this stage, when no treatment and no vaccine are available, this is the only way that we will be able to disrupt the transmission. So yes, the number is increasing. For me, I consider it as a good sign. Although, as we mentioned, a problem, and it's not a super spreader, but we've got a very, very difficult context. As you know, and as I have mentioned already previously, we found, and we did a diagnostic of this outbreak here. It was already rampant and silently disseminating for a few weeks already. So, you know, when we arrived, there was already more than 80 suspected cases that we found. So of course we are also behind. We are running behind now. We are sprinting behind so that we can really try to control this outbreak. And because it is still transmitting for the time being, yes, the number will keep raising for some time until we are really able to put all the response operation in place. So I do think that yes, it is. We would like to have it differently, but we are running behind. We are not yet under control. And I'm telling you, as Dr. Tedros mentioned, we've got for the time being more than 750 suspected cases. And imagine we just have for the time being 1,400 contacts being traced. So we know we are late. I can tell you we are running. We've got insecurity against us. We've got movement of population against us. We've got event like the one of yesterday against us, but we stay strong, determined, focused. We will ramp up. We will scale up our response operation. We are doing it by the day. And I can guarantee you that together, we will manage to get over this outbreak as soon as we can.
Thank you, Nancy. Dr. Janavi, please, Regional Director.
Yeah, on top of what Anansi has just said of improved detection and surveillance, but Ebola has got something called silent early phase, where symptoms really resemble malaria or typhoid or any other. So this means initial cases may not have been recognized immediately. So transmission may have continued undetected to some time. So what we are seeing now may reflect an early transmission that is only being identified retrospectively. The other reason what we see here, they may be linked to challenges, as DG said earlier, is an area where there's insecurity, remoteness, weak health infrastructure. So there can be delays in identifying those cases and transporting the samples and confirming the diagnosis. And Chico here yesterday, I think, touched on the backlog of samples. So you might hear the numbers have gone up. It's not that the cases have gone up, it's just the samples have been clear. And then community transmission dynamics. Ebola spreads through close contact, and transmission can accelerate when cases are cared at home. You see the numbers will go up. Safe burial practices are not followed. We'll see the numbers going up. Trust in response is still being built. So key reassurance here, an increase in cases does not mean response is failing. Actually, it often reflects that the response is intensifying, uncovering the true scale of the outbreak. So the bottom line here is the rise in cases is driven by a combination of early undetected spread and a stronger surveillance. So as we scale up our detection and response, we expect to see more cases initially before the curve begins to go down. Emma, thank you. Back to you.
Thank you very much. And Dr. Mahmoud.
Just to add two indicators that we are closely following. Right now, as you ramp up your surveillance, it's expected case to increase because it's a good reflection. What we've been closely monitoring is what we call the positivity rate. So on 15th May, when INRP declared, we had 8 out of the 13 were positive. That's 62%. And it has been going down. As you ramp up your surveillance, it will go down because you are picking up all other suspected cases. As of yesterday, that percentage has gone to 49%. So your number may be increasing, but we are enhancing our surveillance and not only focusing on the severe cases. So it's a good function of surveillance. We expect the test positivity rate to go down. Another indicator that we are closely monitoring is the death, both the suspected death and confirmed death, because we know very well Ebola, both Zaire and Bunjubuji, early referral and early care saves lives. So when you detect early and you transfer and we provide, it saves lives. So this is a close indicator, and we haven't seen any dramatic increase. When we started, we had 80 suspected deaths, and the number here is 177. So we are not seeing a drastic increase. We expect to see more cases confirmed, but the two indicators we are following as increase the surveillance, improve, look carefully at the death, because we can prevent early detection and early treatment.
Thank you very much. And an add-on, Dr. Van Kerkhoff?
Yeah, thanks. So your specific question on, how much this is going to cost, what we can say is that our partner agencies together with WHO, we're developing what we call an SPRP, a Strategic Preparedness and Response Plan. Our aim is to put out one SPRP so that we show the total amount that is needed for this response. And of course, the plan to be embedded within the national priorities and the national leadership in both the DRC and Uganda. That will take a few days for that to come out. I know that everyone is eagerly awaiting that amount, but I think it's really important, and the DG said this in his remarks, that it's one plan that comes out so that we're not all competing for funds. Funding is challenging right now in the health space, and we all know this, but we do know that there's plenty of money out there. There's billions of dollars that are spent on war every single day. So there's plenty of money that can be handled for this. And what is extremely frustrating is that money will come for a response, but what we actually need money for, and we talked about this before, is prevention. This constant, steady stream of funding to support national governments in the capacities that they have across surveillance, detection, research, infection prevention control, workforce, building trust in communities, et cetera, regularly, as opposed to going into this cycle of panic and neglect, which we all contribute to. So we will be issuing with our partners a strategic preparedness and response plan, again, to focus primarily on supporting the countries under their leadership and bringing this under control. I really appreciate Anne's comments about right at the end, and I hope all of you include that in your articles about we will work together and we will get this under control, because that solidarity isn't just about action, it's about bringing the resources, brain power, human power, energy, collective focus and financing to actually deal with this and, of course, prevent the next one from happening.
Thank you very much. We're reaching the hour line, and DG has to go back to committees, but we have a lot of questions still online. We will take one last. For all the rest, please then bear with us. It's very great to see all your interest. That's important. And then, of course, write to media at who.int. Last question goes to the Times in the UK, and that's Ben Spencer. Ben, please unmute.
Hi, thank you very much. You mentioned candidate vaccines. I wonder if you could tell me what those are and what the timescales are.
Should we start with Dr. Briand, please?
Yeah, so as it was said before, there is no specific vaccine for this virus strain. And so there have been, the committee has not yet done the full prioritization because it's very complex. What the committee has done is first to ask what are the products in the pipeline, and there are many in the pipeline. And so now they are reviewing the list of these products. But to give you a flavor of at least on some products that have been assessed, there was first a vaccine called Ervibo, and this was licensed for the Ebola Zaire virus. But it doesn't, there is very, very little evidence of cross-protection for Bundibugyo. So, this was not really recommended so far as a primary choice. What is probably more promising is the fact that there is RVSV Bundibugyo vaccine, so it's equivalent of Ervibo, but for specifically for this strain. And so currently there is no doses available for clinical trial, but the committee is reviewing the characteristic of this potential product. And if this is prioritized, it's likely to take 6 to 9 months to have it ready for clinical trial. There is another candidate that has been developed on another platform, and so it's on the chimpanzee adenovirus platform, and this potential candidate is a collaboration between Oxford and the Serum Institute of India. They are manufacturing as we speak, but we don't have yet animal data to support the use for clinical trials in human. And so we are waiting for the animal data to see if it could be a promising candidate for research vaccine in this Bundibugyo outbreak. So that's why, I mean, vaccines is certainly a very important tool in preventing transmission, of course. But it's very likely that we will have to wait a few weeks before we get a vaccine that is safe and for which we can prove the efficacy. So that's why we shouldn't stop here. We should continue to implement good surveillance to trace all the contacts. Work very closely with community to make sure that preventive measures are in place to stop chain of transmission, and implement measures, for example, like safe and dignified burial to avoid a super spreading event. And with the therapeutic, we are hopeful that by treating patients, then it will be already reducing the risk of spread, because as you know, patients are very contagious. And so if we can reduce the viral load in patients through effective treatment, this also will be reducing the risk of spread. And then we are hopeful that the post-exposure prophylaxis will be also be implemented and be successful, because then also we have another way to reduce transmission. So this is just to say that when you respond to an outbreak, you need to have a toolbox with full of tools, because you cannot just rely on one tool only. We need a combination of tools, and we need also a multifaceted response that include community protection, access to care, use of preventive measures such as vaccine, and of course an excellent surveillance system that allow us to trace where transmission is happening. Thank you.
Thank you very much, Dr. Briand. That brings us to the end. For everyone, please, we will send the recording and the opening remarks by the Director General soon after this briefing. Thank you all for the speakers and for Dr. Ansia also traveling on the road somewhere in the DRC. With this, again, thanks from my side, and over to the Director General for closing.
Yeah, thank you, Christian. Thank you to our Akanu members for joining us today. And thank you also to members of the press who joined online. Thank you. We will keep updating you on regular basis, and see you next time.